Good morning, folks. Thank you for the opportunity to speak today. I'm Junsik Kwon from Ajou Trauma Center. In the next 20 minutes, I'd like to share our experience with MTP, its principle, practice, and pitfalls. Financially, it's quite obvious that I have nothing to disclose. However, I'm deeply in favor of MTP, so if I sound a little enthusiastic today, please forgive me. I'll try to stay balanced. Let's start with the definition, because I don't want to get lost between massive transfusion per se and massive transfusion protocol. We usually define massive transfusion as at least 10 units of RBCs within 24 hours, or at least 4 units within 1 hour. And activating MTP does not mean let us just pour in blood. It means we commit to delivering the right product in the right amount at the right time under strict control. This matters because trauma patients die from bleeding. Some die from airway issues, of course, but hemorrhage remains the dominant and most potentially preventable cause of death. In other words, this is exactly where we still have a chance to change the outcomes. Our answer to hemorrhage is damage control resuscitation. That includes rapid surgical control of bleeding, permissive hypotension, until definite hemostasis, and early hemostatic resuscitation, where the primary goal is not a normal blood pressure, but control of hemorrhage. Here's the shoot clip on permissive hypertension.
Systolic of 118?
It was 90 after 3 units.
He gave him too much blood and raised his pressure so high that it blew apart the developing clots that was stopping him from bleeding out. Systolic of 90 is ideal. Robbie, you could teach your residents about permissive hypotension?
Yeah, fortunately, we already understand that permissive hypertension is important even during MTP.
Pressure got up to 180.
In practical terms, hemostatic resuscitation means a few simple rules. Do not chase the normal blood pressure too early, limit crystalloids, think of blood early, and activate MTP without hesitation when needed. Among these, balance the transfusion, roughly 1:1:1 with RBC, plasma, and platelets, became the core principle. Several reports showed that giving plasma and platelets early, together with RBCs, can substantially reduce hemorrhagic mortality. The message is simple: be rapid and stay focused on hemostasis rather than volume replacement. Prompt and later proper trial gave the academic backbone to this field. Prompt showed that patients receiving at least 1 unit of plasma or platelets for every 2 units of RBCs had lower early mortality, especially within the first 6 hours, exact the window in which patients bleed to death. So the modern doctrine became straightforward. When RBCs are going in, plasma and platelets must follow quickly. Universal donor product should be available immediately on arrival because the first minute matter much more than the final 24 hours ratio on paper. For that reason, MTP is now considered a core capability of all designated trauma centers. The American College of Surgeons recommends that every trauma center have a formal protocol in place, not an improvised response invented at the bedside. In Korea as well, emergency transfusion and massive transfusion protocols were also incorporated into the National Transfusion Guideline revision in 2016. That was an important step toward wider standardization and accountability. And this is the protocol we currently use in my center. The key lesson was that the benefit of MTP does not come from a cosmetic ratio achieved later. It comes from getting plasma out early enough to matter. So that plasma is not merely catching up with blood that has already gone in. The first challenge is recognizing the right patient early. We try to predict as soon as possible we will require at least 4 units within 4 hours. We use objective tools such as the ABC score, as you see, but if the resuscitation leader believes unstable physiology is due to active bleeding, we activate MTP in any way without delay. Once MTP is activated, the leader's job is not passive. The leader has to direct and verify the key steps in parallel: vascular access, rapid infusion setup, blood product preparation, and communication across the team. In MTP, leadership is really a logistic function as much as a clinical one. Here's another short MTP clip.
Robbie, pelvic crush injury.
Crushing pelvic fracture
100%
patient.
non-rebreathers, drop 120.
Intubation preparation.
Page trauma surgery, please.
Trauma
I
surgeon
got the
comes
fast,
in.
grab a binder.
There's a
Obvious
fast
pelvic fracture.
binder.
BP 68/42, pulse 130. I got a 14 gauge in the
Large
left
bore
AC.
IV
Whole blood massive
diaphragm.
transfusion protocol. Whole blood massive transfusion
comes in
protocol.
threes.
Whole blood massive transfusion protocol.
You're in Youngstown? I'm not sure it's here yet.
Let's go 1-to-1-to-1, red cells, platelets, and plasma. We've got that. Let's place an IJ after the intubation, please.
On it.
Okay,
Yes,
EFAS
yes,
negative,
can
it's all
start with
retroperitoneal.
whole blood, go with one
No
to
blood at
one.
the meatus. Passifoli. Crushed pelvis. Hemorrhagic shock.
ATP, pelvic binder. I'm doing an intubation, about to place an IJ.
Kindly providing summary.
Robbie,
So at first, we secure ABO sampling and vascular access that can truly support massive transfusion, normally multiple 18 gauge or more on upper extremity or sometimes large bore central line. At the same time, we begin with 2 to 4 units of universal donor blood stored in the trauma bay refrigerator. So resuscitation starts immediately and not after the laboratory catch-up. After that, communication becomes the key. We built an electronic MTP button so that activation automatically alerts the blood bank, trauma QI manager, which is me, and anesthesia hotline. MTP only works when several departments move at the same time. Then comes the main transfusion phase. During MTP, when the leader's orders time-matched RBCs, the same number of FFP units is automatically requested. We also standardized the RBC orders in multiples of 4. So the process remains predictable for the blood bank and fast for the patient. The reason for multiples of 4 is very practical. Each plasma throwing machine can handle 8 FFP units, but the fastest workflow is 2 machines with 4 units each. So even the order size was designed around the physical reality of blood bank operation, not just theory. Termination also requires a shared rule. In the operating room, we stop MTP only when the surgeon declares primary surgical hemostasis and the anesthesiologist agrees that the patient is hemodynamically stable without ongoing massive transfusion. In other words, anatomy and physiology both have to agree. Ironically, the same patient who is dying from bleeding can become highly thrombotic very soon after hemorrhage is controlled, like Dr. Kim mentioned earlier. So, in fact, hypo and hypercoagulable phenotypes may overlap, but clinically, we still need to decide when the priority shifts from giving blood to preventing thrombosis. That is why we need to move from ratio-driven transfusion to goal-directed transfusion as soon as the bleeding risk begins to fall. The decision is delicate, and it requires a better compass than fixed ratio alone. That compass is often viscoelastic testing. TAG and ROTEM provide useful information much faster than conventional coagulation tests, sometimes within 5 minutes on your system. They allow us to assess clot initiation, clot growth, strength, and fibrinolysis in real time through parameters such as all time, alpha angle, external amplitude, and LY30. Once we move beyond the initial MTP phase, transfusion strategy is redesigned according to TAG and laboratory finding rather than fixed ratio. For example, when both clot strength parameters are low, we think of fibrinogen replacement or cryoprecipitate. If fibrinogen-related clot strength is preserved, platelets may be the more logical choice. This is where transfusion becomes more precise and more biologically rational. After every MTP case, we review the whole process carefully. That includes coagulopathy, thrombotic complications, ALDs, TRALI, hemolytic reactions, over-transfusion, and TACO. Not a US president. I mean, transfusion-associated circulatory overload. The point is that successful transfusion is not only about giving enough blood, but also about not harming the patient. We also audit key performance indicators recommended by TQIP, the time from activation to the first RBC unit and first plasma, the product ratios, communication with the blood bank, and wastage rate. MTP should be measured, not just admired. To support this in real time, we worked with our electronic medical record team to build a dashboard. It shows how much of each blood product has been requested, delivered, and actually transfused, along with the evolving ratio during the resuscitation itself. We also created a structured retrospective review form because improvement requires both real-time monitoring and formal post-case analysis. At the most basic level, every patient who undergoes massive transfusion enters a case review list. That gives us a routine opportunity to ask what worked, what failed, and what can be improved next time. These quality activities are reported regularly to hospital leadership. For example, in hemorrhagic shock patient, our time to transfusion initiation is now managed at around 10 minutes from arrival. And among patients who truly required massive transfusion, the MTP, that means protocol application rate, is now close to 100%, which tells us the protocol is no longer theoretical. It is actually being used all the time. All of these cases, whether MTP was used or not, are reviewed through multiple forums: the Transfusion Committee, multidisciplinary MTP quality meetings, panel reviews, case conferences, with weekly step meetings. The goal is not punishment. The goal is feedback, learning, and system repair. An effective MTP cannot be built by one enthusiastic trauma surgeon. It is not a one-way efficient order set. It is a shared operational agreement among the blood bank, emergency department, anesthesia, trauma services, nurses, and technicians who actually make it work in real time. For this to work, it is essential to recruit at least one champion from each stakeholder group. Someone who is supportive, motivated, and willing to drive change within their own department. In our case, I would especially like to give a shout out to Professor Young-Hae Lim, the Chief of Laboratory Medicine and also the head of the blood bank. Who provided unwavering and unconditional support throughout the entire development process. We started this project in early 2019, and from the beginning, it was iterative. We kept revising the protocol based on feedback from the people who were using it under real emergency condition. The version I'm presenting today is 8th iteration. So protocol development is never really a one-time event. It is a living process. So I brought the other clip. So it was last month, bilateral leg amputation patient. GCS was 15, away okay, but weak radial pulse. 9 French large central line, and DP was activated with 2 packs of fiber sheep, and BP was 76.
우리 FMS도 체크하시고.
FB 들어갈게요.
언제 하셨어 마지막으로? 점심 몇 시에 하셨어요? 팬이 볼게하고요. 저희
There's the rapid infusion system.
빨리 맥으로 빨리 줍시다.
Raj for central line.
이거는 네네 말씀하세요. 그대로요.
It's real-time tag. Systolic BP goes up 86, but we will stick with the atmospheric tension.
아까 빨리 지혈주로 해야 될 것 같습니다.
After implementation, we performed an interim analysis among 10,059 patients who underwent rescue transfusion. We identified 51 treated with formal MTP and compared them using propensity score matching with patients managed under the previous catch-up approach. And for 24-hour mortality, we observed a statistically significant difference between the groups. That is encouraging because early death is exactly what MTP is supposed to prevent. The secondary outcomes explains why the total 24-hour RBC use was similar between groups, and the overall ratio also looked close to 1-to-1. But in the catch-up protocol, very little plasma was actually given during the first hour. By contrast, the MTP group received more plasma early and maintained a much more consistent balance over time. More broadly, the core elements of protocolized resuscitation, balance and transfusion, restriction of crystalloids, use of TXA, and cryoprecipitate are already routine in advanced trauma system. Many centers now use viscoelastic assay. Some have moved toward dried or liquid plasma. And in the longer term, whole blood and even artificial blood will continue to shape where this field goes next. Let me close with a few recent developments at our trauma center and where we are heading next: pediatric MTP, a multi-center cohort, and whole blood transfusion. I cannot go into all the details today, but after several years of work, we have now launched a pediatric MTP as well. That requires its own design logic. Because children are not simply small adults with smaller blood bags. I didn't do nothing. Okay. We also completed a multi-center registry project on patients with vessel breathing and vessel transfusion together with several trauma centers and some institutions. Through that project, we collected detailed clinical data on more than 700 patients and have already produced several reports and publications from the registry. And after several years of preparation, we have finally started a whole blood transfusion protocol. It is still in an early research phase format, and donor supply remains limited. However, we hope this pilot becomes the first real step toward making whole blood a standard component of massive hemorrhage resuscitation in Korea. To support that program, we developed a formal SOP, standard operational program, for low titer group O whole blood, designed for practical bedside use rather than theory alone. Please excuse the presence of Korean text on some of the slides, as this is an internal SOP document. The first floor is donor recruitment and qualification. The main idea is to identify appropriate donors, verify low anti-A and anti-B titers, and build a qualified donor pool that can be recalled when inventory drops. The second floor is inventory. We operate both central stock and a trauma-based satellite stock. We refill triggers. FIFO, first expired, first out principle, and planned conversion pathway to minimize wastage while keeping blood available where time matters most. The third floor is clinical use. In selected patients, we issue 2 units of LTOWB immediately, reassess ongoing bleeding, and transition to compound therapy. The slide also shows our fallback rules and our specific policy for females or of childbearing age. And behind the algorithm, there has to be complete traceability from donor contact to unit release to bedside use and safety logging. Without that infrastructure, a whole blood program is not sustainable or auditable. The fourth flow is quality management. We defined triggers for reactions, stock failures, documentation gaps, and other deviation. Followed by a structured CAPA process, in other words, every unexpected event must lead to correction and prevention, not just explanation. So here are some take-home messages. Hemorrhage is still the most preventable cause of death in trauma. Transfusion is not just giving blood, it's part of damage control resuscitation. What matters most is early balanced transfusion, not the final ratio. And we should not chase normal blood pressure too early. The priority is hemostasis. In the end, success depends on speed, coordination, and system design. Early recognition and timely activation are critical. Once MTP starts, leadership is about logistics and communication. As bleeding slows, we must shift to goal-directed transfusion using TAC or ROTEM. Continuous audit and feedback are essential for improvement, and moving forward, whole blood and advanced monitoring will shape the future. Thank you very much.